Dr. Alan Menter is with us this afternoon, who's really one of the world leaders in psoriasis, and he's going to be discussing some of the updates in psoriasis in terms of the protocols we use to treat our patient, as well as some of the things on the radar like biosimilars. Welcome.
Well, thank you for having me. Yes, at our annual meeting we'll be discussing the full spectrum of psoriasis, from topical therapy, systemic therapy, phototherapy, biologic therapy, and I'll be specifically giving a talk on biosimilars, which is an interesting new development because of the cost of our biologic drugs, which, as you know, run to about $25,000 to $30,000 a year. Some of these drugs are now coming off patent in the next 2 or 3 years, and already in Europe 2 biosimilars have been approved for infliximab, for Remicade, and will be available. And over the next 2 to 3 years we'll have other biosimilars for some of our major drugs, which will lead to a substantial decrease in the price of these biologic drugs and hopefully open up the market for patients who don't have access to these drugs at the present time.
So I'm hearing you about more affordability and opening up the market for access for our patients. However, one of the concerns that people bring out when we talk about biosimilars is really the companies who are in the process of developing other agents see this as something that may not actually have quite the return on investment that they anticipated. Can you just speak to that to some extent?
Yeah, that's a very, very good point. If prices do drop, which inevitably they will do with biosimilars and new drugs, we have some spectacular new drugs coming down the pipeline, 3 IL-17s that have been spoken about a great deal at our meeting, which have very, very much better clinical outcomes, with 90% of patients clearing. How are the older drugs, which become biosimilars, going to compete with the newer drugs, both in efficacy as well as in cost?
So one of the things that we're even seeing at this meeting is the discussion of biologics and combination therapy. And in some cases, like melanoma, it could be combination therapy from 2 different companies. So are you seeing areas where different biologic agents are used in combination, or something really promising in terms of psoriasis?
Yes, very much so. For instance, even our old drug methotrexate, we've done reviews. We in our clinic have 900 patients on methotrexate and 1,000 patients on biologics, but a lot of that is based on the 2 being given simultaneously. So methotrexate can improve the effect of a biologic. The question you pose, can 2 biologics together? And that research is just starting. The problem with 2 biologics together, either one initially and one like in a melanoma, where you get a complete remission and then you maintain it, is the cost related.
So for patients who have very widespread psoriasis and they've tried multiple modalities, I mean, some of the agents like methotrexate that have been around for a long time are still very appropriate. You mentioned you have almost 1,000 patients on this, and very safe. I think when I trained in residency, this was 13, 14 years ago, we were always told to do liver biopsies and check LFTs. And can you just, for people out there that still manage patients with older therapies like methotrexate, what are the things that you think about, and what are really the updates that have happened in the past few years?
Yeah, well, you're quite correct. We've had methotrexate for 40 years since it was approved, but yet still we don't know why methotrexate only works on, say, 40% of patients. But when it works, it works exceptionally well. The liver guidelines are being changed. Our current guidelines, I chair the guidelines committee, state liver biopsy at 3.5 to 4 grams of total methotrexate. I've got patients up to 5 to 10 grams of methotrexate. I have not done a liver biopsy, even though I'm supposed to follow my own guidelines. So we're now looking at things like scanning devices to look for early liver fibrosis, and there are some other restrictions on methotrexate. You can't give it to a female who's 35, is considering pregnancy, etc. So there are some limitations, and we still don't know why it works only in 40%, but when it works, it works. So that is where the whole market of what we call pharmacogenomics, where hopefully in the next 5 years, and we're fairly far ahead in the dermatology psoriasis world, instead of saying to you as a patient, let's try this drug and see if it works, we'll take a small specimen of blood from you and target it to a specific agent and therefore have a better outcome.
Fantastic. And then lastly, again, older therapies, but really, what do you think the future of phototherapy is? We've seen a lot of practices sort of take their phototherapy unit out, reimbursements down, yet this is something that works very well for our patients.
It works very well either as monotherapy or in combination with our biologic drugs. It works well. It increases the effectiveness. The problem, as you correctly point out, time spent coming into the physician's office to have the phototherapy done, the copay, which sometimes runs to $50 to $75 per patient per treatment. So there is a cost issue involved in it, but it still is a very important part of our armamentarium.
Thank you very much.
Okay, thank you for taking the time.